I am Dr. Isaac Nichols, a PGY2 pharmacy resident at Oklahoma State University Medical Center, and this is a review of my research project with Dr. Kunapoli over the impact of the BCID2 panel and antimicrobial stewardship interventions in patients with positive blood culture identity. The importance of this study is in regards to the positive impact early detection of organisms in blood cultures can have on antimicrobial therapy and overall outcomes. Conventional methods of identification with cultures and sensitivity testing can take from 2 to 5 days, and for some organisms such as resistant enterococcus, such as VRE, or enterobacteriaceae, such as ESBL organisms, this delay in therapy can significantly increase mortality by as much as 4 times the standard rate. The BCID2 is an innovative lab test which can detect up to 43 different organisms and resistance genes within 1.5 hours of the positive culture. This study was to determine the impact of the panel with stewardship intervention on time to pathogen identification, effective and optimal therapy. Additionally, we aim to compare post-intervention data to a 6-month period prior to intervention for secondary outcomes, including total and ICU length of stay, microbiologic cure time, all-cause 30-day mortality, and 30-day readmission with bacteremia. Lastly, we recorded the interventions and responses made by the antimicrobial stewardship team. For our methods, we designed our study as a quasi-experimental type comparing 2 6-month collection periods prior to and after implementation of the panel. We utilized myself and Dr. Kunapoli as the antimicrobial stewardship team who worked on call from 7 a.m. to 10 p.m. We included adult patients with at least 1 positive blood culture on the panel who was at OSU Medical Center, patients with blood cultures at another facility or without an organism on the panel, as well as patients who moved to CMO or died within 1 day of culture were not included. Our primary outcomes were time to pathogen identification, effective and optimal therapy. Secondary outcomes were total and ICU length of stay and microbiologic cure time, and our safety outcomes were all-cause 30-day mortality and 30-day readmission with bacteremia. In our results section, we will start with the demographics for our intervention group. Both groups had a majority of male patients, with most being close to 60 years old and at least obesity class 1. Nearly 2/3 of the patients had diabetes, and 1/3 had CKD, ASCVD, and heart failure. For our preliminary primary outcomes, we did show a reduction in time to pathogen identification with a negative 20.8 hours. There was a small decrease in time to effective therapy at negative 2 hours and a large difference of negative 15.8 hours in time to optimal therapy. Our preliminary secondary outcomes show a similar but slight decrease in microbiologic cure time and a substantial difference in total and ICU length of stay with over a full day difference in both categories. When we assessed the intervention analysis, the majority of them, 78%, fell within 3 categories: de-escalation, discontinuation, and continuation of therapy. Another important category is the escalation of therapy, which was primarily seen with resistant organisms such as VRE and ESBL organisms. Our preliminary outcomes for safety events did find a higher number of deaths and readmission with bacteremia in the post-intervention group. It is unknown what the clinical significance of this is due to the low number of events to produce statistical analysis. Now let's discuss some important points for interpreting this study. So some strengths of the study that we've seen: this is completed with active patients on standard of care for our hospital. We attempted to design the study to mimic the hours staffed by clinical pharmacists who will be trained to aid in interpretation of the panel. Second, our inclusion-exclusion criteria allowed a largely diverse population, including ICU, general floor, surgery, and other patient groups with a myriad of diagnoses. Lastly, we utilized appropriate stewardship for the complete care of the patient, which at times necessitated further diagnostic testing and continuation of empiric antibiotics prior to changes in therapy. This continuation of empiric therapy and coverage of sites of infection also limited the full difference in time to effective therapy or optimal therapy if possible. The second and third limitations involve the exclusion of patients due to them being discharged from OSU Medical or having an organism not included on the panel. In conclusion, we found that the implementation of the BCID2 panel shortened time to pathogen ID and optimal therapy significantly, with a similar time to effective therapy between the 2 groups. We viewed a trend of shorter total and ICU length of stay with a lower time required for microbiologic cure. There were numerically higher rates of death and recurrent bacteremia in the post-intervention group. A final analysis is needed to further investigate a possible significance. Finally, further studies may be needed to determine the utility of the BCID2 for patients discharged or with patients with negative results. Here are your references for more information on this topic specifically. Thank you for your time.